All right, I think we're going to go ahead and get started. I did go ahead and remute all lines, so Todd, you might want to make sure that you're not muted. Just a couple of housekeeping things for those of you who haven't used the Zoom meeting before. You can put your mouse down towards the bottom and you'll notice that there's a little chat bubble that comes up. So if you would like to open chat and say something, you can. Once you open the participant view, if you would like to, it'll show up on the right, and you can say, go a little slower, I don't understand, or go faster. Those things will be marked. At some point, I'm sure that Todd will open up the lines and take questions and answers. So if you would be more comfortable either putting those in chat or opening your line, that would be great. So since it is right at 2 o'clock, Todd, you're unmuted, and I think everybody knows who Todd is from the State Survey Agency, and we're just really thankful that he gives us this time. You're on.
Okay, well, thank you, Pamela. Again, welcome to everybody that's out there listening or has questions. Pamela did forward me a group of questions. I think she had a total of like 17 or so, and that's great. Had a chance to work on most of them. I've got a couple that I may have to have some clarification for. Yeah, I think it was 15 questions anyhow. So we can go through that and pick them up on our next call if I didn't exactly answer the question that somebody had. So bear with me. I'm not going to go into much detail about us. I'm going to just go right into the questions here and get started so we can, in the best interest of time, get through everything we can. Trying to advance. Oh, here we go. All right, so the agenda, these are the questions I had come in. As you can see, a listing of those. So I'm not going to read through them, but those are the ones I'm going to address today the best I can. If we run out of time, I'll just pick them up next time if we run out of after the hour. Okay, so the Bounds portal for incident reporting, that's the new web-based system that you can log in and report any facility reportable incidents like abuse, neglect, exploitation, etc., that is required under CMS requirements. And each provider can identify as many staff as they need to be able to enter that, including the administrator and DON and CNAs, anybody. It's up to you to set that up. I've given you the login location for that. It's a pretty simple process. We hope it's going to make it a little easier for you for reporting and your staff. That's the goal. The other benefit of this, and I'll kind of go over these in the next slide, but is to allow you to report to not only us, but the ombudsman at the same time. So it's one reporting portal that goes to both of us. So that was one of the benefits of this, and hopefully you'll find that a better way. The only thing you will have to continue to do is report to your local law enforcement if it's a criminal type activity. Example would be a rape in the facility. That has to be reported to your local law enforcement. Anyhow, there is also a chat feature on this website. There's no phone-in number. There's a chat feature though that you can, chat with the owners of the database or the portal system itself and ask questions or whatnot if you're struggling with any kind of the components of the system. We also in our office have two folks, our compliance specialists, Brittany Nelson and Becky Yancey, that are familiar with the system and have used it as well. We do see a different side of it as far as we accept the results of the investigations and everything like that, and kind of serve as an administrator for that whole system, so we can add and edit things, as far as who's able to input things. Just today we had one of the long-term care providers has changed hands from one corporation to another, so there's 13 facilities throughout the state. So we've helped some of those folks coming on as new administrators or new staff with new emails try to kind of balance that out. So again, there's our phone numbers for our two people that are pretty good at it. And then if you want to email, that's the best place to send it to, that mtssad@mt.gov, because that comes to a kind of a general inbox that multiple staff can see, and if somebody's gone, you can, somebody will be able to pick it up and answer your question. So some of the benefits, like I was talking about a little bit, it is web-based, so it allows more users to come in, and I don't believe we have a limit on users. I think we've seen as many as 25 right now that are input as users, and they can, send out these incident reports. It does go to the Certification Bureau and Ombudsman, like I mentioned before. You can review the history of the submittals. So if you're questioning whether you submitted something or not, or where it's at, you can go back and look at it and verify it's there and when you sent it, that kind of thing. So it is it's a repository in my mind for your submittals of incidents. And if the system is down, you can go back to the fax system if you would like, or the Montana File Transfer Program if it has, specific information about the resident that you don't want to just send through email. And Montana File Transfer Program is available just by Googling that file transfer, and you'll see it for Montana. Pretty straightforward process, but it is a secure way to send information like that. Fax, of course, is another secure way to do that, and at least they tell us it is. So again, when you do the file transfer, you want to send it to that mtssad@mt.gov, and we could receive it. Our old form is still out on our website, so if you want to report on the old form because the Bounds portal system is broke, you can go out there and use that form. But we prefer you to use the Bounds portal because it's easier for us as well as you, we hope, and it makes it better for us as far as just sheer processing of paperwork versus electronic information in our system. So anyhow, that's the Bounds portal system. It's been in use since August 1st. If you do have questions, I go back to the contacts. Those are the folks that can help you. Again, there's a chat feature on that Bounds portal main web page. It is kind of difficult to see where it is. It's an orange bubble on the upper right-hand side of that system, and it's a chat box. If you kind of mess around with it, you can figure it out. But they could help you as well with some of the, getting through the process and understanding how it works. It's pretty logical the way it's set up, and hopefully you find it useful. If you don't and you have comments, please let us know, and we'll do what we can to modify or make a change. I think one of the first things, and I think Pamela identified it, or one of the folks that spoke with her, was that they limited it to, I think, 4 or 5 staff members. So anyhow, they could provide any kind of incident. Well, they've expanded that. So thanks to those comments, we've made changes already to it. So anyhow, that's the Bounds portal system. The final word on this is that CMS is actually working on a new upgraded system to where it is all web-based. And when I say system, including our survey reports. And so they're in the midst of developing that, and they're telling us that they're going to have an incident reporting system as well. I don't foresee it for about 3 years, but that's my guess. But they are working on something. So this is just a temporary use thing until they come up with some system that's a little more user-friendly, I think, for the providers and for us. So anyhow, is there any questions on that Bounds portal system that I can address right now?
Todd, I might have missed it. Is there a location for the recording for those who were on vacation or out that day?
Oh, good question. Yes, there is. I don't have it right at hand, but I'll forward it to you. Let me get that as a note here, and I'll make sure and get it to you, Pamela.
Excellent. Thank you.
Okay. Okay.
I don't see any other questions. I will monitor chat for you. So just remember, guys, you can go down and click on that chat bubble and use that as well as unmuting yourself.
Okay, thank you. I'll just keep going on then. The next one I was going to talk about is psychotropic medications and gradual dose reductions. One specific question that came in about Aricept was whether it was psychotropic or not. It is considered a psychotropic. The one thing that I spoke with, and I've got to say that I'm not the expert on this. I've got many staff here in the office that are, and they spoke to me about a gradual dose reduction can be attempted unless it is clinically contraindicated. And so, and I think Pamela just recently sent me a good question that came up, and I'll kind of discuss that as well as part of the response to this. This other question related to this Aricept question was melatonin, whether it's considered psychotropic. I don't believe it is. I found it somewhere at one point, and I don't know where I seen that in the regs or in some kind of guidance that was given to me. I've got to research it more and figure out where exactly that is. But I'll get a response to the group on that as far as melatonin. But to me, it isn't, to what I recall. But again, let me find out a final answer, and I'll share that with Pamela, and she can distribute it. One of the key elements of noncompliance that we look for as a survey agency when we go in and look at psychotropic medication use, and then as we're analyzing it, of course, all this information is entered in the NDS system, and so we kind of know that that data is coming to us. As you probably can well understand, that CMS's new long-term care survey process incorporates that NDS quite a bit and helps us make selection of what residents to look at or what residents to take as part of our sample. So that's where some of that's coming in. But these are I think there's 6 steps here, or 6 things that must be considered by the medical staff when they're reviewing a psychotropic, and whether they can continue to use it with that person or that resident without having to reduce it or take it completely out of their prescription, or take them completely off the prescription. So these are the 6 items we look at. I think, and it's all under this F758. If you want to Google that on CMS's website, it'll give you the whole regulation. But in that regulation, it also gives you guidance that the surveyors use to decide, okay, did we have an issue here with F758? And I think, and many of you may be able to tell me a little better, but I think one of the bigger issues that has come up is not checking the PRN prescripts after 14 days or something like that. CMS put in a new requirement that after 14 days they have to be reviewed. So I think that's been catching a number of the facilities unaware of that change. So that's one. Going back to that particular one, the example that Pamela had was recently we had a zero deficiency survey in one facility in the state, but yet Pamela brought up that they have a pretty high use of psychotropic, or it's not pretty high, but they've had, I believe it was an increase in their use from quarter to quarter of psychotropics. And so if we go to the regulation again and we went through this process, that's how we look at it from a survey agency. Whether that's right or wrong, I can't tell you. Whether CMS will improve that process and try to identify more, again, I don't know. I think this new system is so fresh in the way it's being used and being worked, the bugs working out of it and everything. It may change in the future, but not to my knowledge as far as this portion. I think they have to use it and try it out and see where it's working and where it isn't working. It is one of the pushes from CMS to do these gradual dose reductions and reduce the amount of psychotropics in long-term care. But with that being said, I don't have all the answers right now. I have looked at the regular data that CMS provides to us. I guess it's quarterly. And the last one, just looking at it, Montana was ranked number 38 out of 50 states. But one of the things I will commit to do is look at some of the other states that I know of that have reduced things a little better, or had a more success or better ranked. For example, I think New Jersey, they are now ranked number 2. I'm going to have some discussions with them and see what they found successful, and share that with Pamela as well. I know some of it is, and we've had this happen with us as well, is that if we come forward and almost act like we're practicing medicine, then the Board of Medical Examiners has had complaints filed on our surveyors for practicing medicine without a license. So we've had that happen. So we've got to watch what we do as well. We're not doctors per se. So we've got to, stick within the requirements and follow what CMS is requesting us to do, and be thoughtful of how we approach it. So I don't know if somebody has any more specific questions on this. It's a topic that it's a tough one in the sense of, how do we reduce this, and then yet the folks that end up in long-term care at this point, and some of you probably know much better than I do, but are the more challenging people to deal with as far as where they are in their medical diagnosis and with their behaviors and things like that, that can be challenging. So I don't know, I'll open the floor up again for any questions or comments on that.
So this is Pamela, and I have a couple things. To avoid confusion, what I want to draw attention to is Todd's slide is psychotropic medication, and the difference between a psychotropic and an antipsychotic. So Aricept is a psychotropic, but it is not an antipsychotic. And originally, what CMS did is they focused on antipsychotics. They have since, in the new regulations, opened it to all psychotropic medications. The call for a minimum of a 15% reduction over a 5-year time period is what CMS mandated, and Montana that's the measure we are failing, is antipsychotic reduction. I know that there is a challenge with physicians, and if you have physicians that are challenging you, we do have a medical director, and he is actually reaching out to physicians and talking to them about their prescription use, which is outside of, it's off-label or black box warning. The huge concern is those who have dementia that are on the medications because it is so harmful. So just want to kind of make sure that we draw a line between the difference between psychotropic and antipsychotics, because antipsychotics is a separate measure, and yet it falls in line under psychotropics also. So if you have questions for me, that's fine. We can get to them later, but I'd rather use the time on Todd. And I do not see any again in chat. If you want to unmute, please just go up there, you hit participant, and you hit the unmute, and we can hear you. If that is for some reason not working, let me know in chat and I will unmute you.
Okay, I'm going to hit on to the next question and get through that. Infection control, and I'm not sure, it just came as a kind of an open-ended, it just said infection control. So I'm assuming some of the interest is based on what I've provided here. The infection control plan, or infection prevention and control plan, the IPCP, is one of the things that is in the regulation set itself, and I've given you the different regulations. It talks about the system having one in place, the written standards and policies and procedures of the facility itself, the recording system of how that's going, special requirements with linens and how that's treated, and then an annual review. The other thing that has been added to this is, and you'll see it in there, it's to be implemented in November of 2019, November 28th, and it's about infection preventionists will be required by that date. And so they've given some guidance, and it's very, to me, very short, not real descriptive, but it is in the reg, F882, and the interpretive guidelines, really there isn't any at this point. It's just the regulation they're repeating. And it tells you how they qualify. They qualify, you know, they should have professional training in nursing, medical, et cetera, microbiology, epidemiology, or a related field. A related field, I don't know what that would be, but that's what it states at this point. Qualified by education, training, experience, or a certification as an infection control specialist or something. They have to be at least a part-time staff member, and they must complete a specialized training in infection prevention and control. And so the one thing we are aware of is that CMS has issued some guidance after the fact, after they did the change, is that in spring of 2019, they're going to offer some training that specifically, it'll be free, but it's specific to this infection prevention and control. And that's what we're aware of right now. I do see that by the time we get to this regulation, there'll be some changes to it as far as some detail added as to what do they mean by related field. What do they mean by what kind of certification, education, et cetera, would be qualifying. I'm hoping, I don't know for sure, but that's my hope. And then, you know, this training, you'll all have a chance to take that. It's spring, is what they're saying is spring of 2019. We'll sure keep PAMLA and the other providers in the state, you know, as up to date as we can, as we know it comes out. And obviously we'll have to take it as well. Our surveyors here in the office. So that's what I have on infection control that I thought was of relevance. I don't know if anybody had any other additional things they wanted to discuss, but that's what I put together for today.
Todd, I can hear you very well, but I do see in chat where one group is having trouble, they said, hearing you, and they're asking if you could speak up.
Sure, I'll speak up. I'll get closer to my phone here.
That's the only comment I saw in chat.
Okay, do you have anybody? Okay, so no chat. I'm going to just go to the next question then about emergency operations. And it talks about, and again, I'm guessing what the question was about, but here's what I prepared. Emergency preparedness planning, events requiring defend in place or evacuation, those kind of things, loss of power, natural disasters such as fires, earthquakes, flooding, accidents on highways next to a facility, for example. So the emergency operations part of it, as you can see, CMS, of course, at this point, our life safety, we have 2 life safety code surveyors that are evaluating all long-term care facilities for their emergency preparedness. So that's what we're going to look at. And we basically write a report similar to a life safety code or a health report that gives you a grade on how you're doing. Is there deficiencies? Is there none? And in fact, I'll cover this a little bit more. Somebody asked about the top deficiencies or common deficiencies. So I'll kind of discuss that a little bit later in my presentation, but I assume this is what they're talking about. As you all recall, these long-term care facilities, I'm unaware of any in the state that have life support systems for any of their residents. So they're not required to have generators. However, most of them do have generators. And the one thing to keep in mind with generators is they're not providing power to the entire facility. It is limited as to what they provide. So, in fact, we had a issue come up up in the Scobie area where they lost power due to wind, or a microburst tore down some power lines and some big power lines. And so they were on emergency operations at that point, contacting, again, this is a new system or new requirement CMS has been having us do in recent years, is communicating with the facility and make sure where they're at, when they're going to transfer anybody, if they're going to do that, are they defending in place, etc. So that is what I would assume emergency operations, the question was about. And again, I'll share a little bit further when we get to those common deficiencies, and here they are. I wanted to share this one website that kind of lets you do a review of what we have been citing. If you go to this website, you can put it, pick it by state, by facility type, nursing homes, and you can look at what we've been writing as far as deficiencies. It'll even pull it to whatever facility it is. It'll give you the name of the facility. But it'll show you what kind of deficiencies we've been writing, if you're interested. So I based my data here is based on that. It's just a kind of a data clearinghouse that stores everything for CMS. So what I did is I put together the most common tags for health, for any of the health deficiencies we write. And you can see what I also did is added how nationally the same tag ranks. So in Montana, for example, the #1 tag we write is develop and implement a comprehensive care plan, and it's under F656. Nationally, that's #3. So I give you kind of a comparison of what nationally number of citations we wrote Montana versus overall, which would include us as well, but 23 for us. And this is looking at the data since we started the new survey process in December of 2017. So just we're a little bit over 7-8 months into the survey process, the new one. So you can go through here and kind of see where we're writing things. Infection prevention and control is #2 for us. It's #1 throughout the country, but we've issued 19 deficiencies on it, and et cetera. So it goes through there and kind of explains where we're writing things as a state and then as a nation. Anyhow, this is just some data comparison right now. I think it's good for us as well to kind of see where we're at compared to everybody else. Are we focusing on something that isn't as irrelevant throughout, or is irrelevant throughout the rest of the country? So this is data we're going to look at as a team as well. So going on, here's for life safety code. Here's the various things. Again, I did the same comparison to show you what we have been writing in life safety. Sprinkler system maintenance and testing is a big issue. Of course, as you all understand, one of the big pushes by CMS was to have all long-term care facilities sprinkled with fire sprinkler systems. And so this is one of the key things we look at all the time. So you can see there we wrote again those most commonly since December again. So going through this, you can kind of see where we're at, what things are coming up commonly. Some things, like this one raises a question for me. Doors with self-closing devices. We're #6. The nation is 29, and I'm wondering why is that? We should probably be more in line with what nationally is going on. So those are things we will consider internally and see what we're doing that's either wrong or doing differently. So Then going on, here's the last one, the emergency preparedness. It comes out as a different report. Again, it's done by your life safety code surveyors, and it kind of shows you what we're writing as far as emergency prep testing requirements. That's the number one for us, and that's the number one in the state or nationally. And so it gives you the deficiency tag number is E0039. So if you're curious about what that means, what emergency prep testing requirements mean, that's what you want to look at. You can kind of see again our ranking on the nation as far as how we're doing versus the nation. But this gives you an overall view of what we're writing as well. This is new for everybody, so I would assume it's going to be even more difficult to kind of get the data or to be more consistent throughout the country as things go along. So those are the most common tags, the top 10 for those three areas that we write deficiencies in. And we will update those at any time. You can go to that website. It'll give you the top 25 if you're interested. Or it'll give you them all. It'll give you every deficiency we've written in Montana since you can pick the time frame. So next question, I'll go back to that. Does anybody have any specific questions about top 10 deficiencies and where we are as a state with that? Okay, Pamela, do you see anything in the chat?
I don't see anything in chat, and I heard thank you after you apparently got closer to your phone, so I think all is well.
Okay, sounds good. I'll go on to the nurse aid training removal and CMS enforcement. This is one that I've heard quite a few comments about, and actually have shared this with CMS in the regional office about the frustration of, and I think it even starts at a G deficiency now, that you remove the nurse aid training program if there's an approval in the facility when we cite such a deficiency of that level or higher. And one of the things I've been looking at is we do have a waiver process. If there's some conditions, and I'll kind of show you, you can apply for those waivers if you feel that you're in an area that you cannot get continued CNAs or a nurse aid training program that will help train CNAs for your facility. And you do have the option to IDR this process too, if you'd like. What I'm learning is this is one of the S&C that I think will provide more information, and I'm going to provide this to Pamela as well. It does talk a little bit about being more of a state-enforced issue than it does being federally. So I'm going to go down that road to see what we can do to make a difference in this, because I, much as you, agree with if you write up a deficiency as a G, the last thing we want to do is pull the CNA program from the provider to continue to provide good trained workers for that, for that long-term care facility. So let me take a look at it further. This S&C that I put up here on the screen provides some details to me to where I can, analyze it and decide what we need to do here in the office. It also lists waiver possibilities. And for example, if it's a smaller community, we can certainly, it's a little easier because one of the requirements is determine that there is no other such program offered within a reasonable distance of the facility. So if you're, and I'm not picking on anybody, I'm just saying if you're Garfield in Jordan and you're really the only long-term care in that area and there is no other options, it's probably an easier determination for us to issue a waiver to allow them to continue if they lost their CNA program. Just one example, there's others throughout our state that's widespread as we are. The other thing is, it looks like we can evaluate as a department here through oversight effort that an adequate environment exists for operating the program in the facility, and it says provides notice of such determination assurance to the state long-term care ombudsman program. So we've got involved on ombudsman as well and go through that process. So we certainly would do that. So that it does give me a little more leeway, I think, in what we understood as our limitations on it. So good news, I think, in that sense, and hopefully will help some of the providers out there to continue to get good staffing, or good trained staff, staff that. And I know the ins and outs of you telling me that, we train folks and then they leave to go to someplace else, or, they won't let our staff in because they're training for their own internal needs and et cetera. So anyhow, we'll look at that from our standpoint as well and see what we can bring to the table as a stakeholder in this as well. So I don't know if there's any questions on that. Okay.
I don't see anything in chat, but I bet that some people are pretty excited about that news.
Yeah, I think it's something I truly appreciate you guys presenting questions to us, because it makes us look at things differently at times and makes us stop and say, well, what can we do, or what are we doing that we can change? So I appreciate this dialogue as well as much as you do. So keep the questions coming. We can always improve in our office as well, and so please don't hesitate to contact us. So the new long-term care survey process, why did we go to that, and why that change? The best I could find, and it's kind of directed by CMS. It's something that they needed to change, and I think some of it is tied to the ACA, the Obamacare. That kind of mandated it, as well as the Impact Act that required some changes with home health and things like that as well. So those are some of the regulatory requirements, but some of the examples they give, or they provided to us, is two different survey processes existed. They had the traditional one that you all experienced here in Montana. That's all we used. Other states went to that quality indicator survey, the QIS, which was kind of the latest and greatest version of what they thought would improve the process. So what they tried to do is take both of them and combine them and come up with a better survey process. So that's why they came up with this, and they just call it the LTCSP, long-term care survey process. They don't have some real neat name for it or anything. That's all they call it. But it did. Some of the surveyors identified opportunities to improve efficiency and effectiveness of both survey processes. So between the two, the combination of both and the process, and what was cumbersome, what wasn't. The two processes appeared to identify slightly different quality of care, quality of life issues. So again, they combined them. And then CMS set out to build on the best of both of those and establish a single nationwide survey process. And one of the things, I've been here a little over 10 years in this department, working in this arena of regulation, and it is pretty clear that consistency is important, especially for providers that have multiple facilities. They often point out to us that we're not being consistent, and it's good to hear from our standpoint to say, hey, what are we doing here? Why are one group of surveyors doing this? Why are one group of surveyors doing this, or such and such person? So I think this new process offers us a little more consistency. Hopefully you'll see that as well. And that's one of the main reasons I think it's of value to us. The goals of the new process, these were set by CMS. Same survey for the entire country, of course. They got rid of the traditional and QIS. They used the strengths again from the two previous type of surveys they developed. New innovative approaches. They're hoping it's more effective and efficient, and it's resident-centered. That's one of the things that CMS is really kind of pushed with us is resident-centered focus, and so that's what we've been told. Balance between structure and survey autonomy, so self-governing. Again, I bring into that consistency of one surveyor doing it one way and the other doing it a different way, just based on pure human nature of maybe interpreting it differently. That, as you can imagine, is a challenge, and I'm sure you've seen it. So those are the things that why we changed to this new process. I think one I hear mostly about from CMS is the resident-centered care, and it being focused on each individual resident as far as what their needs are, what their care requirements are. So that's the best of my knowledge why they've done it, but those are, that's the explanation I received anyways, or was presented to us when they introduced it. I'm sure, just like we all know here in Montana, the consistency between us and Wyoming may be different, or South Dakota or North Dakota. Each regional office, like Denver, serves, I think, 8 to 9 states. And each regional office is a little different than each. There's 10 total, I believe there's 5 different regional offices throughout the country for CMS, and they interpret things a little differently, as you can imagine. So their goal is to try to get that so it's consistent across the board, no matter where you are in the country. And again, providers with multiple locations, multiple state facilities get a better feel for that than any others do. So, so anyhow, that's what I know as far as why they chose to go with this new survey process. But I can tell you, for me, consistency has always been something I've tried to push and get our folks to be as consistent as we can. So let us know when we're not doing that. I don't know unless you let me know. So any questions on that particular question that came up?
I see nothing in chat.
Okay. The next item was facility assessment, and it talks about, again, I didn't know quite where the person was going with the question, but maybe a discussion on it will cue some questions. But F838 talks about a facility assessment, and the facility must conduct and document a facility-wide assessment to determine what resources are necessary to care for residents completely, blah, blah, blah. It's all, language written by CMS and their legal teams and whatnot. But basically, the example I thought for facility assessment that I can bring forward to you, that to me that was one of the key issues of why a failure occurred in a facility or a deficiency was identified, is basically taking on a resident that maybe has different needs, and sometimes because of isolation in our state, we may not have all the medical professionals available within reason from closeness to the facility, or maybe across the state or whatnot. But this is what this facility assessment is kind of looking at, is making sure you have the needs for all the residents you do take care of, and then thinking about it as you do take on new residents. Are they bringing in something that we don't cover? Is it something that is new to us? Do they have such special needs that we need to retool some things? Do we need to have certain lifts purchased? Do we need to make changes to how we care for a particular individual? So that to me is what this is about, is to continuously look at that. Are we taking on different type of residents that are challenging us? Are they bringing different disease processes in that may be of a little more complex nature and require additional professionals? Those kind of things. And it's also kind of tying into a hazards approach, the looking at emergency operations and how you're going to continue to operate with that in mind. It is what kind of people do we have? How easy is it going to be to transport a person that is maybe they cannot go out on their own. They cannot self-preserve in the sense of being able to even evacuate. It's going to take additional time, additional special needs to get them to evacuate. So those kind of things, I think, as well as what the facility assessment's wanting you to do. It does say in the intent on this particular reg that it says it is for the facility to evaluate its resident population and identify the resources needed to make the necessary care and services the residents require. So again, I'm not going to bring up the facility name or whatnot, but just taking on somebody that was unique in their sense of their needs, it put them in a bad situation. We certainly appreciate their willingness to help their community and support whoever they have coming in, but sometimes that can put you in a bad spot as far as the survey process, not having the correct equipment on site to support that person, whether it be feeding or bathing or whatever the care they need. Those things can catch you. And again, they may have not had in this particular example, obviously they improved the care when they brought them into the facility, but it still was not up to a level that met the survey requirements. So they may have, in other words, they came from a worse environment. Their care was very questionable. That, as they come into the long-term care, it became even more of a challenge for them to meet the needs of that resident and support them. They got there, but it took us somewhat to identify that everything wasn't being met. So anyhow, that's what I would say for facility assessment, is to continuously think about that. I'm sure you probably have thoughts in your mind as to some of those folks that may have come in that have really made it hard to deal with. And so one of the ones that I think of quite a bit is smoking, and we're going to cover that here as well. So any questions on facility assessment?
I see one asking if providers can ask for a daily update with surveyors or the team leader to discuss areas of concern, clarity on if the surveyors have asked and have been given items such as care plans, falls, logs, etc. Yes,
they can certainly ask for it, you bet. It is not something CMS requires us to do at this point, but they can ask for it, absolutely.
Does that answer your question? We'll wait and see if something else comes up in chat, but for right now, that's it.
Okay. And then going on, like I was leading into the smoking policies for residents, another question that somebody brought up. We did recently have an IJ related to injuries to a resident when smoking. It was in May of this year. And part of it was control of the lighters and cigarette issue. Person was on oxygen. Their oxygen was off, is what we believe in even as well. But the problem with oxygen, it isn't an explosive per se, but it creates a residual or a higher concentration after you start breathing it in that area, even in a room. Normally we're 23% oxygen in the atmosphere, but it can increase the, that amount of oxygen if you're breathing it around you. It can increase the flammability or the combustibility, I should say, of your clothing, much like it does in surgeries. They've had people ignite on the surgery table, and it's pretty common. And they've tried to battle that as well. But this person had a nasal cannula still in, and it ignited the cannula and burned her face. So it does. One of the things that you got to consider with this is the liability of the facility. Really, it's upon the facility to protect that resident and keep them freedom from abuse, neglect, and exploitation. Of course, this area we're going to talk about is neglect. So it tells you that CMS requires them to maintain that free from neglect. So there is specific requirements in there that talks about resident smoking. And then it also talks about under F689 about accidents. The facility must ensure that, the environment remains free of accidents, hazards, as is possible. And each resident receives adequate supervision and assistance devices to prevent accidents. So, and then they tell you the intent is to ensure the facility provides an environment that is free from accident hazards. That's what we would have wrote this up on. Identify hazards and risks, evaluating and analyzing those hazards and risks, implementing interventions to reduce hazards and risks, and then monitoring for effectiveness. But do we have to control the lighters and the cigarettes of residents that come in the facility that we know are smokers? That's up to the facility to determine that. If you feel they're a hazard or going to try to smoke in the room, that's the other thing. Think about it. Most of the long-term care facilities do not have smoke detectors in resident rooms. It might be a good indicator that they're trying to smoke in the room, but if you open the window and you start smoking in the room, you may not get caught the first 3 or 4 times or whatever. Staff may walk in and catch it, smell the smoke or whatnot, and know that it's been occurring, but maybe getting there to that point. We have had accidents in this state where we've lost people doing that very thing, burn themselves up in. It was prior to my time, but they were smoking in their room and ignited either clothing or whatnot, hiding in a closet. And then again, it's not the fire that kills them necessarily, but it's the smoke that's generated in that room. And of course, it'll stay in that room if the door's closed, if the closet's closed, whatnot. So it's up to the facility to decide how to do that, how to control those hazards. And smokers, we have smokers here that work in our department as well. And to, by golly, take their smoke those cigarettes from those folks, you wouldn't want to do that. So, there's that desire to do that. Some facilities claim they go towards a non-smoking campus, and that's all good and well. But again, if you get somebody that is a smoker and they come on site, and then you tell them, oh, they've got to go across the street to smoke or out away from the signs that say this is a non-smoking campus, you're still putting that person in risk and in danger at times, especially in winter conditions where they're going across the street or whatever to smoke. Just not a good policy. So you're going to, again, evaluate what you're able to do in that facility. If they're good about following the policy of non-smoking and everything, that's one thing. But if you've got one that's pushing the envelope and doesn't want to quit smoking, you're going to have to evaluate what your best options are. And certainly, there are ways to discharge as well with people that are non-compliant, because they obviously do affect, if they're smoking in their room or whatnot, they can affect more people than just themselves if they ignite a fire. Anyhow, so smoking policies for residents, those are some of the things I can think of that we've faced or seen. We just want to be able to, prevent those accidents, and that's what they hold you to. Here's some more on supervision, adequate supervision. This is where it comes from, that regulation as well. They do, so they define that somewhat, but they also provide, CMS provides in the accident, that F689, I believe is what it is, the new tag. Yeah, 689. They talk about residents smoking, and they talk about whether it's a smoke-free or if it's a facility that is, that does allow it. It doesn't matter. They're not mandating which way you have to go. That is up to the facility. But they must identify the needs and protect that person from that side of it. The facility can designate certain areas for resident smoking, and et cetera. Again, it's up to you to manage or mitigate that liability as you allow this activity to occur. Obviously, oxygen may prohibit it from being in, even folks that are non-smokers coming into the smoking area with oxygen on or whatnot. So anyhow, those are the other side of this is life safety also covers the this part of making sure that residents are responsible enough to smoke on their own independently, don't need direct supervision. So it comes from both health and life safety that they warn you about this part of it and the accidents that may occur with it. So anyhow, these are the areas that I'm aware of in the regs that cover this. It's not completely prohibited, but again, that's up to the facility to decide what they want to do. And then, you know, if they decide smoking is okay, then they've got to address it as well. So those are the kind of the examples that I have for smoking that I could think of. If there's any other specific questions, I'd be willing to answer them now.
Todd, I don't see any related to that, but I do see a comment on the last question saying, "This is great news. We were denied the ability to meet with the surveyors and were told they could no longer do that. Some reassurance that the surveyors know that we can meet with them."
Sure.
Also,
I will discuss that with the surveyors as well.
okay, during the exit survey, an agreement between the surveyors and the facility that they have asked for certain documents and did not receive it. This would avoid unnecessary time on the back end of the survey for everyone involved, as well as the hours of IDR preparation.
Sure, and I agree to that partially, but I can tell you we've had experiences of providers generating documentation after the fact. And so that's the other side of it that is concerning to us. So that's why we request the documents when we give you a certain amount of time to respond to that and provide it. So so keep that in mind as well.
I'm not sure, but I think the way I read that is they just want on, I think at exit, clarification of what documents they want so that they could get them to them on exit. That's how I'm reading it.
Okay, I got you. You're right. We can do that. I will make sure we discuss that in our next meeting with all the surveyors.
Yeah, I think that they're just trying to speed the process up a little bit and say, if you need something, let us know right away so that we can get it to you. So maybe even a quick little checkbox, like we'd like this, 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 and this, and hey, we received this, 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 and this, and that might be handy.
Sure, and I think that's what we are using, but I will, I will come to back with some answers on that. I believe they are using checklists like that, but well, I'll make sure. I'll find out. The other part of it is to keep in mind CMS's new push with this long-term care survey process is that, as you all know, we don't go for a site tour when we come in. We go in and we do observations of residents with residents for almost 8 to 10 hours. So that's the initial, kind of push that CMS has pushed us on and has required us to do. That is different than what it used to be in the past, where we did the initial tour and, toured with the facility staff and went to each room and blah, blah, blah. That has changed. So that is a little different as far as our approach. But we'll look at the other side of it and talk about what we can do as far as updates and things like that, okay? Okay, the last one I think I'll have time for today is this glucometer use. I think the questions were about use of the glucometer for multiple people and, disinfecting them. And CMS actually has provided some pretty good guidance in there. I won't go into great detail on it, but it is within the F880 tag, and it talks about multiple use. It talks about point of care testing and gives you some information to use or as resources. One of the other things you want to think about with these WAVE tests is what they're called from a laboratory standpoint, Clinical Laboratory Improvement Amendments, or CLIA. Many of you have certificates of waiver to conduct testing in facilities. And basically it's with these tests that are waived, such as glucose monitoring, pretty simple processes that they follow through. But they have to still have some kind of a disinfection process between uses, between residents. The other things that I've heard surveyors discuss, and it's come through in IDR and things like that, is doing that kind of event in the dining hall. Making sure that you've got approval of the resident, whatnot. You can't just do that as a practice. The other things that you want to think about is following the manufacturer's directions. If they tell you how to do certain tests, you follow their directions. And that's what you can present to the surveyors as well. As far as, this is, hey, we're following the manufacturer's directions. That's what CMS is requesting us to do as well. So there is a little bit of tie. We do have the CLIA laboratory inspector and our surveyor here in our state within our department, Joy Shepard. She's also a good source for this information about glucometer use and these wave tests as well. She's a laboratory personnel, so she kind of knows that ins and outs of that. So I use her as a reference as well. And again, this F880 talks a little bit more in detail about blood glucose meters and using them in each device and how to follow the process. This one talks about, for us, it gives us a note in here: if the facility fails to clean and disinfect per device manufacturer's instructions and blood glucose meters are used for more than one resident, surveyors may cite the tag and utilize the guidelines in Appendix Q, which is the immediate jeopardy appendix, as it may constitute immediate jeopardy. So those are some of the references I would look at and consider as you go through or have questions on that. If you have more specific things you want us to answer, you can send them through Pamela, and we can address them there. I think I'm close on time. I think we're at an hour at this point. Pamela, did you want me to end it at this point or continue on? Or?
We don't have any questions. We've had about 4 people drop off. How much more do you have, Todd?
I think, well, then we've got a couple more slides. So.
Well, do you want to just wrap it up?
Sure, I sure will.
I know that people can quickly vote too. There's a no. You can check a no. It's in that participant thing. So it's being recorded. I say if we're almost there, let's do it.
Okay, I will wrap it up. Conditions of participation versus recommendations. And I assume, again, I'm reading into this. I don't know what the exact question is, but when it tells us in the regs you must or you shall do something, that's to me something that has to be done. If it's a recommendation by our staff or whatnot, we do not survey the recommendations. That's not our job. We are there to survey to the regulations and not, recommend or suggest recommendations for anything. You survey for the minimum standards is what, in all reality, so that's what we're looking at. If you have concerns about what we're doing as far as whether it's we're giving you recommendations or whatnot and you're uncomfortable with it, you've got my email, my address right there. Please call me directly. I'd like to hear about it. Because, again, this is, as a regulator myself, and in the past, I've been on the other side of it, and as a person that's been regulated, it is important for me to stay within the regulations and not, go beyond that and push too far outside of it, or any outside of it at all. We're not here to be heavy-handed. So let's open up that communication. Let me know if you have questions, and if you have concerns, I'd be more than happy to talk to you and let you know what I know and what I can find. I often end up doing kind of a review of what the staff are doing, trying to learn from what they're doing as far as in the field, and trying to improve on that too as well, or make improvements when we need it. So, and then the final one I had was access and functional needs. And it listed education of volunteers. I don't quite know where this is going. But one of the things that I would bring up as an example, as far as training for people, including volunteers, we've had, as an example, folks that were volunteers that had come in and were helping feed residents. in the dining area. They weren't necessarily paid feeding assistants or anything like that, but they were still in the facility feeding residents. They should be trained as well on, if they're going to do that, on the same thing anybody else that would feed residents should be trained on. So you need to make sure and carry that through. Same with travelers, traveling staff, family members, etc. They should be trained as well. The other thing I was thinking about related to this is some of the traveling staff may have abuse reporting covered under their provider. Say they work for, and I'll just throw in Prairie Travelers, for example. They may provide abuse training, but you need to provide your abuse training to them as well in that facility so they understand the protocol as to how they report things, etc. So again, that's something we look at as well. And I know that's difficult with those travelers because they may not be there very long, but again, they have to have that training as well. So those, I don't know if that addresses the question, but I will be glad to have any comments sent into Pamela about different things we need to address on our side of things. So, or if I didn't answer the question somebody had. So with that, those are the slides I prepared today. And hopefully they answered your questions. If not, let Pamela know. And please call me with any question you have.
All right, that's great. I want to thank everybody for joining us. Thank you, Todd, for taking the time to put this together and answer questions. We did pretty darn good. We're at 6 minutes after the hour, and I already have several questions that have come in for next time. Please complete the survey. If you have things that you want to have Todd talk about next, I don't know, Todd, did you have a topic plan for the next time, or were you relying on input?
Yeah, input is great because then we address the questions that you have, and I'd rather do that. Chances are there's something that everyone's struggling with or wondering about. So please, yeah, any questions you've got, and we'll work through them and respond.
Okay, well, I put in chat the Survey Monkey address to put those questions in, and Todd, I'll go ahead and zip off the ones that came after our cutoff this time. Thanks, everyone, and I hope you have a great day. Bye-bye.